Thank you for having me, and I will get started as people filter into the room after what I'm sure was a nice lunch and discussion. So these are my disclosures. I'm going to have a running case throughout this discussion. So this is a 52-year-old male, typical patient who comes to his PCP's clinic with several months of weight gain and lower extremity edema. Blood pressure is a little bit high, and on exam, really the only pertinent feature is that this patient has 3+ pitting edema up to the knees. The physician runs some lab tests. Kidney function is fairly normal, but the serum albumin is low at 2.9. The cholesterol is quite high, and automated urinalysis shows 4+ protein with trace blood and no leukocyte esterase. So due to this unexplained nephrotic syndrome, the patient is hypoalbuminemic, proteinuria, has edema. If you looked at the urine, I think you did urinalysis this morning, you'd see oval fat bodies, you'd see lipid casts, and a 24-hour urine protein that's quantitated at 13 grams. The patient is referred to a nephrologist who schedules a kidney biopsy. The biopsy report comes back several days later showing membranous nephropathy with IgG and C3 present as fine granular deposits in a capillary loop pattern. There's no tubular interstitial fibrosis, no atrophy, no global glomerular sclerosis, so the rest of the kidney looks pretty good. So I'm not going to do the audience response here, so just think about the right answer, note it to yourself, and then we'll go on. I have a lot of slides to get through in 45 minutes. So which of the following statements about primary MN is incorrect? That it affects males twice as commonly as females, that it affects only Caucasians, that the median age of onset is in the mid-50s, or that 30 to 40% may undergo a spontaneous remission. So think about that for 3 seconds. And the incorrect answer is that it only affects Caucasians. I've seen it in most ethnicities and races that we've studied. The frequencies may be slightly different, but it can affect anyone. Males are affected twice as commonly as females. The median age, if you look at all the table 1s and the studies out there, is about 52, so low 50s. And about 1/3 of patients, if given enough time, will undergo spontaneous remission. So what is membranous nephropathy? And I hope you've seen some pictures in Dr. Reinke's talks so far today. But it's a leading cause of the nephrotic syndrome in adults. We know it's an antibody-mediated kidney disease. And I'm going to call the common autoimmune form primary membranous nephropathy. You may see in boards questions, you may see in the old textbooks that this is idiopathic, but what I'm referring to is the autoimmune common form of membranous nephropathy. It's an organ-specific autoimmune disease, and it has a variable course. Some patients will go into a spontaneous remission, some will have persistent proteinuria, some will end up going towards end-stage renal disease, and if a patient is transplanted, it can recur in the allograft. When I talk about secondary MN, these are the membranous nephropathies that occur due to lupus, class 5 lupus nephritis, hepatitis B, certain solid tumors, and certain drugs like NSAIDs, in the old days, gold salts, penicillamine, etc. There is an alloimmune, so antibodies against foreign proteins that can occur, as Pierre Ronco described in 2002, in a very rare neonatal form of membranous nephropathy, anti-neutral endopeptidase, where the mother was genetically deficient in this protein but was immunized during a pregnancy. And probably the de novo form of membranous that happens in transplants is an alloimmune reaction to some donor antigens. Just remember, like all these diseases like FSGS, MPGN, that membranous nephropathy is a pattern, not a specific disease. Idiopathic, I will reserve for those cases where we don't have a target antigen identified yet, maybe 10 to 15% of otherwise primary disease. When I refer to primary, this distinguishes the autoimmune form from the form of membranous that occurs with cancers, malignancies, lupus, infections, etc. And primary can be identified, and I'll talk about these, into the antigen that causes the autoimmunity, so PLA2R specific, THSD7A specific, etc. So natural history of membranous. Unlike diseases that have an explosive onset like minimal change or primary FSGS, the onset of membranous nephropathy is very slow. So patients can come to you reporting weight gains, leg edema that really have gone on and increased over the course of months. In general, when these patients present, about 75% of them are nephrotic, so over 3.5 grams of protein, but some show up to you and they may have subnephrotic levels of protein. Many of these, about half or so, will progress to nephrotic levels, especially if they have circulating antibodies that are perpetuating the deposits. And the rule of thirds you may see, so 1/3 will undergo spontaneous remission, 1/3 will be left with persistent proteinuria, and the last third will progress, often in the setting of very heavy proteinuria, towards renal failure. When we think about the resolution, and this is a point I'm going to hammer home through the talk, the resolution of the proteinuria is very slow. It takes time for these deposits, which you'll see in the next few slides, to be resorbed and the slit diaphragm and the filtration barrier to be restored to normal. So you may have seen some of these already, but membranous nephropathy is named because the basement membrane is thickened. So we see in the PAS stain over here some very thickened membranes. And when we do the Jones methenamine silver stain, we can really appreciate the thickness of the membranes. You can often see, and can't quite find them here, but craters in tangential sections of the basement membrane where you have the deposits which don't stain with silver, or you can see spikes that are the basement membrane that's laid down between the new deposits. So you can see that on the Jones stain. The immunofluorescence gives this very typical pattern, the fine granular peripheral capillary loop staining pattern. You can see this for IgG, you can see this for complement factor 3, and as you'll see later, if you stain for the antigens within the deposits, you can see the same pattern. On EM, we see the very pathognomonic subepithelial deposits right below the effaced podocytes, the simplified body of the podocyte sitting above it. The endothelium looks normal in this case. The fenestrations are still there, but the podocyte will have this microvillous change. So you see these projections of what look like microvilli extending into Bowman's space. So what is in this? I've already mentioned on immunofluorescence that we see IgG, we see complement factor 3. If you stain for C4, you'd see that as well. And the antigen there. So this is a big complex of antibody-antigen deposits. And schematized in a review I wrote with David Slant, you can see in the primary form, the autoimmune form, you may have circulating antibodies to a intrinsic podocyte antigen like PLA2R, which the antibody antigen complex is formed, they're shed into these deposits, complement is activated, which then damages the foot process, and you get the simplification of the podocyte and loss of slit diaphragms. There are other forms where the antigen is planted, meaning that circulating antigen, this could be hepatitis E antigen, this could be cationic BSA, traverses the negatively charged basement membrane, lodges here, and then an immune reaction occurs. So you get deposits formed to these planted antigens. And there may be cases, maybe lupus, where you have circulating complexes that for some reason don't lodge in the mesangium or subendothelium, but end up in the subepithelium. Some people have proposed that the deposits are disaggregated, then reaggregated. I don't know if there's a lot of evidence for that, but that's a theory. So let's get back to our case. So the nephrologist is unsure whether or not this membranous nephropathy represents primary or secondary disease, and she requests that her patient be tested for circulating anti-PLA2R antibodies. So we're now just after, so a month ago, we had the 10-year anniversary of the M-type phospholipase A2 receptor, or PLA2R, as the target antigen. And what we found was that this protein is a normal component of the podocyte, shown in red here. And then in certain individuals who develop autoimmunity to this protein, those over time, the antigen antibody complexes shedding into the subepithelial space will allow antibody, which in this picture is green, and PLA2R, which is red, to be exactly in the same place. So the pathologist can stain for PLA2R and see that same picture. So why was this such an important finding? Well, we know that before this time, we had nothing to follow when we were treating our patients or waiting for spontaneous remission, other than what their kidney function was doing, how much protein they had, and what their serum albumin was doing. And we know now, I guess we knew then, that clinical remissions do occur slowly. So now, with the detection of these circulating antibodies, we have a serological marker that we can follow as another measure of disease activity. And the important thing is that the serology precedes and predicts the clinical course. So we're allowed to make more rapid treatment decisions. And I've schematized this here. So we typically find our patients in this region where they have the deposits on the biopsy, they have a lot of protein, and if we measure the anti-PLA2R, it's often high. And with treatment or with spontaneous remission, ultimately we'll get the protein coming down. But what we notice first is that the antibody levels come down and can be followed declining and disappearing. If we were to do subsequent biopsy, we'd see that the deposits have stopped forming. They start becoming these stage 4 resorbing deposits. And really only then can we have the healing of the podocyte, the restoration of the slit diaphragm, and then we see the proteinuria coming down. And when we look at curves that define the probability of achieving remission, we see, and I'll show you this later in actual studies, that the remissions occur years out. So 1 year, 2 years, 3 years until you get patients having complete remissions. So again, to summarize, we know that PLA2R is a normal podocyte protein. In primary membranous nephropathy, about 80% of patients will have evidence of this disease system being active. The antigen will co-localize with IgG in the deposits. I'm not going to talk about it here, but there's been a GWAS study showing that there's a genetic association with the PLA2R gene locus as well as with the HLA system on chromosome 6. The finding of either circulating antibodies or the presence of PLA2R within the deposits is highly specific for membranous nephropathy in general, mostly primary, although there are some reports of, say, hepatitis B being associated with secondary, so it's not always 100% specific for primary disease. So the assays that are out there, there's an ELISA, in which case the PLA2R protein is plated at the bottom of the microplate, and you're just asking how much circulating antibody is present. The current assay goes from 2 to 1,500, so people in papers have looked at different tertiles and said, you know, this might be a low level, moderate level, high. It's very relative, so I don't think a single titer can tell you anything in the whole range of patients with membranous. You have to look individually at a patient. Is the titer going up? Is it going down? Et cetera. There's another test, which is the cell-based assay immunofluorescence test. Similarly, cells are transfected with PLA2R, and you're asking, are there antibodies binding this set of cells and not the untransfected cells? That's a little more subjective, but it's a good and sensitive test for the presence of antibodies. Or you can have your pathologist stain the tissue instead of the 5 immunoreactants, IgG, M, C3, and C1q. You can add an antigen-specific test, staining for PLA2R. Again, 80% or so will have the presence of PLA2R in the deposits. Now remember, this is a normal podocyte protein, so why don't we see it? Well, if you look here, this is a patient who doesn't have PLA2R-associated disease. There is some hazy, dull background staining. Just at the level that this antibody is used by pathologists, you don't see the normal protein. You just see the aggregated protein when it's present in the deposits. So there is a group, about 10, 15%, that we can call non-PLA2R-associated membranous. And between 2009 and 2014, when we knew the existence of another antigen, that's all we could say. But in 2014, we in a group in Hamburg, Germany and Nice, France, co-identified THSC7A, so thrombospondin type 1 domain containing 7A, as the second antigen in a small proportion, about 3% of patients with primary membranous nephropathy. Everything seems to be the same. We find the antigen THSC7A co-localizing with IgG4 in the deposits. When we took biopsy samples from patients and we eluted with acid the antibodies from the biopsy, we could show that in the cases of THSD7A associated disease, there was only IgG to that antigen and not to PLA2R. In certain cases of PLA2R, we only found antibody to PLA2R and not the other antigen. And in class 5 lupus nephritis, we found antibodies to neither. Now, that being said, there are a few, I think 11 in the world, reported cases where there's a coexistence of antibodies to PLA2R and to THSC7A. But I don't think that will ever show up on a board's question. So back to our case. So the result comes back, the circulating antibody test is found to be positive for anti-PLA2R antibodies at a moderately high titer, say 300. The renal pathologist has also stained the biopsy tissue for PLA2R, and it shows the same pattern for IgG, a strong staining in a fine capillary loop pattern. But the nephrologist is still a little concerned, is this primary, might this be secondary to something else that's not been found yet? So what should we think of? So about a quarter of the cases are secondary, and these can be secondary to lupus. Sometimes it's the first manifestation of lupus, and the patient will be ANA negative. So consider class 5 lupus nephritis. Hepatitis B infection can certainly cause membranous. Certain solid tumors, lung, prostate, there are a lot of them out there, can cause membranous nephropathy. NSAIDs, but also mercury-containing compounds. Some skin lightening creams used overseas contain 10 to 20% mercury and have been associated with membranous, or gold salts historically. Cationic BSA is something that Pierre Ronco found in infants who were fed certain types of milk formulas that happened to have derivatized cow proteins, and found a few cases of formula-induced cationic BSA-associated membranous. Okay, so another question to think about. Don't raise your hand, don't use the buttons. But which of the following findings on biopsy would favor primary over secondary disease? So staining for C1q, predominance of the IgG4 subclass, the presence of subendothelial and mesangial deposits, or the presence of endothelial tubuoreticular inclusions. So I hope all of you will realize that IgG4 is more indicative of primary than secondary, and all these others, the presence of C1q or a full house pattern, the presence of deposits other than so in addition to under the podocyte, or the presence of tubuoreticular inclusions, which can occur in lupus or HIV or other interferon-based signatures, would be a secondary cause of disease. I'm going to skip over this one that's in your syllabus and go right to this table. So several features should make you think about secondary disease. So again, if you've identified a potential secondary cause like lupus, hepatitis, drugs, tumors, if the immunofluorescence does give the full house pattern with the presence of IgA, M, and C1q, in addition to this IgG and C3, if there's an IgG1, 2, or 3 predominance, that's probably not primary membranous. Again, mesangial or subendothelial deposits. And there's some literature showing that tumor-associated membranous may have more infiltrating immune cells in the glomerulus, which usually isn't a feature of membranous nephropathy. Now, a lot of concern is out there if you diagnose a patient with membranous nephropathy, how strongly should we work up malignancy? These are often older patients. 50s is the median, but there are a lot of patients in their 60s, 70s, and 80s that get this disease. They can also have coexisting cancers. There may be similar processes that can push someone towards membranous and towards malignancy. There's a paper from China showing that air pollution and particulate air matter can be associated with membranous nephropathy, smoking possibility, so maybe these same processes are inducing both. The studies that have looked at the incidence, the standardized incidence ratio of malignancy, does find that compared to the background rates of cancer, that patients with membranous tend to have more malignancies. There are several reports out there, one from the Hamburg group, showing that tumors can overexpress THSD7A, and those patients then develop, or maybe concurrently develop, THSD7A-associated membranous nephropathy. So possibly in those cases, the tumor is the primary disease and then causing a secondary membranous. So we need to think about this, especially with THSD7A. And especially if you have a patient and you look in the biopsy and there's no PLA2R, and your pathologist does the subclass staining and there's really not a lot of IgG4. These are the patients that we should think more carefully and make sure they've had their age-appropriate cancer screening. If they're a smoker, maybe get a lung CT just to look for that possibility. So I like to think about this schematic when I think about what's going on in membranous nephropathy. So something starts the immune process. In red, the trapezoid here, this is the anti-PLA2R going from low to high and then maintained at a high level. And then something, whether it's spontaneous remission or treatment, causes the PLA2R to go from high to low to disappear. And if you were to stain that patient's biopsy, probably in very early disease to even after the clinical disease has stopped, you're going to find the antigen within the deposits. So the blue line shows the proteinuria, which lags behind because it takes time for these deposits to form to cause the injury for the patient to become proteinuric. And then even after the deposits, the antibodies have stopped appearing in the circulation, you still have the deposits there. They're still causing some sort of defects in the slit diaphragm, and it takes a while for that proteinuria to come down either to a complete remission or to a partial. So when you find a patient whose biopsy shows PLA2R in the deposits, but is seronegative for PLA2R, which would be over here, generally that patient is on their way to a clinical remission. Now you might say, okay, am I going to catch a patient here? And there are some case reports of patients who seroconvert, their biopsy shows PLA2R, they're initially seronegative and then they go to seropositive, but those are very rare. We don't find these patients clinically because they don't come to clinical attention. Again, it's months and months of disease before the patient really realizes that they have foaming urine, they have leg edema. So generally we tend to catch the patients here or afterwards. Okay, yeah. So back to our case. So age-appropriate cancer screening is done, including colonoscopy, doesn't show any evidence of malignancy. So the nephrologist decides on conservative therapy with diuretics, with ACE inhibitors or ARBs, with statins. And over the next 6 months, this patient's blood pressure is reasonably controlled. The creatinine stays stable at 1.2, but the serum albumin hangs around 2.9, and the 24-hour urine collection shows that there's still 10.7 grams of protein. So the patient and the nephrologist discuss the benefits and risks of immunosuppressive treatment. Now, we know a lot about how to manage sort of clinical signs and risks for progression of the disease with whether or not we should immunosuppress. And this is work that was done by Dan Catron in Toronto that showed that if you have less than 4 grams of protein, you're really not at high risk for progressing towards worsening kidney function. But if you have sustained proteinuria over 8 grams, these are the patients that do tend to progress to worsened renal function. So the Toronto algorithm proposes that if you have less than 4 grams, you can just use conservative therapy and wait to see what happens. If you're in the 4 to 8 gram range in yellow here, you can wait for 6 months with optimal conservative therapy, see if you can get them under 4. If not, you should start to treat. And if you have over 8, you only have a shorter waiting period of 3 months or so. Or if the patient has worsening kidney function or severe nephrotic syndrome, you can start immunosuppression immediately. We'll talk about the treatments, but the 2012 KDIGO still recommend alkylating agents and prednisone as the first line, and then calcineurin inhibitors as an alternate first line therapy, with rituximab reserved as a second line. This just also is in your handout, but if the patient has a life-threatening PE, severe nephrotic syndrome, or if their kidney function is worsening without other explanation, that might be an indication for early treatment. If they have fibrotic, shrunken, atrophic kidneys, if their creatinine is very high, or if they have a severe infection, we're not going to treat these patients with immunosuppression. More recently, the Mayo group with Dick Glassick has come up with a serology-based algorithm for whether or not we should treat. So you can look at this, but basically, if the patient has high levels anti-PLA2R and their titer stays high or is going up, these are probably the patient we're going to want to start immunosuppressive treatment. If they're nephrotic and their titer is high or going up, again, they even recommend that if you have non-nephrotic range proteinuria, so 2 grams, but their titer is rising, we could consider treating. I would probably wait to see what's happening with their proteinuria and kidney function. Maybe they're going to have a spontaneous remission. So take that with a grain of salt, whether or not we want to start these patients immediately. Because immunosuppression has risks. Cytopenias, infection, infertility with alkylating agents, malignancies, nephrotoxicity with the calcineurin inhibitors. But the risks of no treatment, especially worsening renal function, I think is the biggest concern. The risk of venous thromboembolism, PEs or renal vein, and the other consequences of nephrotic syndrome. So in terms of blood clots, which patients should we consider anticoagulating? So we know that in general, 10 to 40% of patients will have some form of venous thromboembolism, and the risk increases the lower the albumin gets. This group from the UNC in Toronto actually showed that 2.8 grams per deciliter is sort of the cutoff range below which the risk starts to increase. And they predicted benefit to risk ratios according to bleeding risk and albumin level. And what they found is if you have low bleeding risk, it probably makes sense to treat if you're below that 2.8 threshold. If you're below 2 grams per deciliter of albumin, the benefits outweighed the risks by 13 to 1. If you're an intermediate bleeding risk, it's about 5 to 1 benefit over to risk once the albumin drops below 2. But if you're high bleeding risk, it probably doesn't make sense to treat with warfarin. So thinking about the non-immunosuppressive treatment, we have ACE inhibitors, ARBs, we have diuretics, statins, these should always be used. Warfarin, depending on the level of serum albumin. And if we get to the point where we're deciding on immunosuppression, again, KDIGO would suggest, and there are 2019 guidelines coming out, so I think this will change somewhat, but the modified Ponticelli regimen, which I'll show you, prednisone and an alkylating inhibitor is first line, and then calcineurin inhibitors are alternate first line. Don't use steroids alone. Maybe in Japan this will work. Their disease tends to be a little different, but in most studies out there, monotherapy with prednisone is not effective for membranous nephropathy. So the initial Ponticelli used chlorambucil. That was found to be a little too toxic, so the modified Ponticelli used cyclophosphamide. And this 6-month regimen has months 1, 3, and 5 with 3 days of IV methylprednisolone and then oral for the rest of the month, alternating on months 2, 4, and 6 with oral cyclophosphamide. And there's 10 years follow-up from 2 different groups. We know that those patients that are treated retain kidney function, whereas if you're not treated over 10 years, many of these patients lose renal function. The combined partial and complete remission rate is almost 90% by 10 years. Complete remissions about 50% by 10 years. There was another group in India that showed the same thing using the modified Ponticelli. And again, treated group had excellent survival without dialysis or survival without reaching this renal endpoint up here versus being not treated. And complete and any remissions occurred years out. So again, it takes a while to attain clinical remission in membranous nephropathy. This is the only slide I have on calcineurin inhibitors. There was a number of studies, small studies done in Toronto by the Catran group with cyclosporin. I think many of us feel more comfortable with tacrolimus these days. So this is a study by Manuel Praga from Spain, where he used tech monotherapy for 12 months and then tapered over 6 months. And you can see that the proportion of partial in white and complete remissions in the darker gray increase over time to almost 80% by 18 months, which looks good compared to control. But then once you take these patients off their tacrolimus, many of them go back into relapse. So you lose all of these complete and partial remissions. And I think that's been the general finding, that maybe 40 to 50% of patients, once you taper off their calcineurin inhibitors, will have a relapse of disease. Other limitations, so the calcineurin inhibitors can aggravate hypertension, they can cause tremors, there's impaired GFR, there's striped fibrosis on biopsy, some of them are diabetogenic, and the relapse rate. Alkylating agents may be even more concerning. We worry about bladder and hematologic malignancy risk, infertility, gonadal suppression, and the prednisone component can be quite toxic and diabetogenic. So despite all of this, the nephrologist and patient go through the options, they look at the data, the 10-year follow-ups, and they decide that maybe the modified Ponticelli has the highest likelihood of putting this patient into remission. And indeed, within 3 months, the anti-PLA2R has declined, and by 6 months, the anti-PLA2R is completely gone. The renal function remains stable, blood pressure, volume status is good. The urine protein to creatinine ratio is 5.2, down from over 10, and the anti-PLA2R remains negative. So what do you want to do at this point? So it's still nephrotic amounts of protein. Do you want to start tacrolimus, a different regimen? Do you want to try rituximab? Do you want to repeat the Ponticelli or continue supportive therapy? Now, I hope most of you, seeing that even though the protein hasn't fully come down, hasn't achieved a partial remission, which would be under 3.5 grams, that the anti-PLA2R is negative. With continued supportive follow-up, the protein should continue to drop. So that's what I would do. Again, we know that these remissions occur well after the treatment phase. So I've indicated with the line here, this is 6 months. This is when we give the Ponticelli regimen. And we know from the literature that these complete and partial remissions occur years out. So you need to have a little patience in this disease. We also know, and this is retrospective study by the Wetzel's group in the Netherlands, looking at patients who are treated with cyclophosphamide or another cohort that was treated with mycophenolate. They were only looking at patients who were anti-PLA2R positive at the start of treatment, and they asked, if we finish the treatment and the patient no longer has anti-PLA2R, they do quite well. At 5 years, the majority of them have not relapsed. If we don't completely suppress anti-PLA2R, in this case it was 9 patients, they quickly go back into a clinical relapse. So it's very important if the patient starts anti-PLA2R positive to continue treatment until that antibody level is virtually gone. So indeed, our patient is continued on supportive therapy, and over the following year, the proteinuria values come down from 5 and eventually get down to 0.2 grams, so a complete remission with a stable creatinine. The patient, now in complete remission, continues to come back every 6 months or so to see the nephrologist with stable function, regular checks of the protein creatinine, until 4 years later. At this point, the patient has a protein creatinine ratio of 1.8, which over time continues to increase. The creatinine is going up a little bit to 1.5, and the nephrologist says, I don't think we need to repeat the biopsy. I think we know what's going on. Let's check another anti-PLA2R, which comes back very positive at 342. So the patient's a little worried at this point, read about the use of cyclophosphamide and the risk of malignancy, so he says, I'm not doing this again. Nephrologist is a little worried about the increasing creatinine, doesn't want to recommend calcineurin inhibitors, so let's think about rituximab. So what do we know? And this has changed in the last month since I made these slides, but there are several small US and Canadian studies from the Mayo and Toronto about rituximab, based on a large Italian, so the Bergamo group in Italy first used rituximab in a small study group that has led to over hundreds of patients being treated with rituximab with very good observational data. It works as first-line therapy, as second-line therapy, and this is all we had until Pierre Ronco and his group came out with the GEM-RITUX study. I learned that GEM in French means membranous nephropathy. I won't try to pronounce it in French. And that compared the B-cell depleting agent rituximab to supportive therapy. The primary endpoint was 6 months, so it didn't really show anything, but with extended follow-up, rituximab worked. No surprise. And then the MENTOR study finally came out on July 4th and showed that at 12 months, rituximab was non-inferior to cyclosporin, but at 24 months, all those cyclosporin-treated patients had relapsed, so it was actually shown to be superior. It was not intended to be a superiority study, but at 24 months, rituximab was superior to cyclosporin for the treatment of membranous nephropathy. And this is just some of the Ruggianenti, Ramuzzi, Bergamo group data showing that in general, rituximab treatment leads to a very high rate of combined partial or complete remissions. This is the first line therapy. This is if it's given as second line, pretty good effects either way. So in our case, the patient gets 2 doses of 1 gram of rituximab spaced 2 weeks apart. Anti-PLA2R comes down a little bit, 40%, when tested 5 months later, and the nephrologist appropriately recommends a second cycle of the rituximab. Unfortunately, the patient was feeling good, wasn't having too much proteinuria, too much swelling, so didn't come back for follow-up. Misses a lot of his follow-up appointments after that. Why is this important? Well, again, this is from the Italian observational study, and in many patients, so all patients treated with rituximab given sufficient doses will deplete their B cells. Many of these patients, if you follow the anti-PLA2R after treatment, their antibody levels come down and they stay down. There is a group, and the ones that do have this response are the ones that have complete or partial remissions. There was a group that the antibody levels came down a little bit, but just got hung up and never declined further. These were the ones that had no response to treatment. So these are the ones that need either a change in immunosuppression or another cycle of the rituximab. So unfortunately, back to our patient, you find that with this lack of follow-up, the patient quickly progressed to end-stage renal disease due to persistent nephrotic syndrome and ended up on dialysis. However, his wife has offered to donate a kidney and it appears to be an acceptable candidate. So you check this patient prior to transplantation and find the anti-PLA2R has slowly declined on its own and is now down to 45. So which statement is correct regarding the probability of an outcome of recurrent membranous in the allograft after transplantation? That it rarely recurs in the setting of our current immunosuppressive regimens, or despite a high likelihood of recurrence, it's often mild and non-progressive, or, and I'll just quickly go to the right answer, that it can recur in up to 40% of cases and can lead to graft loss in those with persistent nephrotic syndrome. Remember, these cases had pretty aggressive membranous nephropathy from the outset. These same antibodies are now attacking a single kidney, so it can certainly be a progressive disease with loss of allograft function. So if you look at the literature, the rates out there are from 10 to 45%. The lower rates are those that don't do protocol biopsies and rely on clinical recurrence, which tends to happen in about 13 to 15 months. Those centers that do protocol biopsies at 3, 6, 9 months, et cetera, tend to find the deposits earlier. Whether or not they will at all progress to clinical disease isn't known. But these are the 43, 45% rates. And we know that just like in the native kidney, anti-PLA2R can be associated with recurrent disease. The first report of THSC7A was in a recurrent case. So we know that if you have antibodies to THSC7A, those can recur in the transplant. Just some summary points. Using the presence of anti-PLA2R or anti-THSC7A pre-transplant has a very poor positive or negative predictive value for recurrence. But it is important to know, especially if you know that the patient had PLA2R-associated disease or THSC7A in the native kidney, then you can use the titer pre-transplant to have an indication is, might this come back? I don't think the presence of the antibody should really exclude a patient from transplantation, but it should make you aware that maybe this might come back. I know the Mass General recently had a case with a very high titer anti-PLA2R, and they had to make some treatment decisions prior to the transplantation. So as I said, heightened surveillance for proteinuria is warranted if the patient is found to be seropositive. And then it's important to follow them after transplant. And in many cases, you're putting them on, if you have a non-steroid-free protocol that they're getting calcineurin inhibitor, they're getting prednisone, they're getting mycophenolate. Often that's enough immunosuppression just to push down the levels and there won't be a clinical response. But in those patients whose anti-PLA2R remains high, increases, then they need extra immunosuppression, and often rituximab is what's suggested. So in our case, the patient receives a living unrelated kidney allograft with excellent function. The anti-PLA2R levels do decline and disappear, and the proteinuria after transplantation remains stable. So happy ending, end of case. So what I want to take home messages, and this is all in the syllabus, to remember that PLA2R is the major autoantigen in primary disease, which still may be called idiopathic disease in some cases. THSD7A is another minor autoantigen found in about 3 to 5%. There are other ones out there, which will not necessarily from me, but others are looking at what other antigens might be out there. So you might hear about some more. We know that testing for the antibodies to these antigens can have clinical relevance, as can staining the tissue of the biopsy for the presence of these antigens within the deposits. In this new window on membranous nephropathy, it really allows us to see things happening quicker before waiting for the proteinuric response. If you have a patient who's suspected membranous or has membranous on biopsy, and you get a negative serologic test for anti-PLA2R, this could mean that the patient has already gone into an immunologic or serologic remission. It could be that you're dealing with another antigen, so consider sending for THSD7A, even though that's not a widely available test yet. Or consider looking for secondary causes if you haven't excluded all the potential secondary MN causes. Remember that serum albumin less than 2.8 is a major risk factor, and this is where the risk of venous thromboembolism increases. Probably if you're asked this question in the next year or two, I would still say that the alkylating agents alternating with prednisone or calcineurin inhibitors are considered the first-line treatments, but rituximab is certainly an up-and-coming agent, and I think recommendations will change in the next few years on what we should be using first. Remember that membranous nephropathy can recur in the kidney allograft. So if the patient had membranous and it comes back, then that's recurrent. If the patient had some other disease and you see membranous in the transplant, that's de novo disease, often occurs years out, and is probably due to alloantibodies against donor antigens. If you have anti-PLA2R or anti-THSD7A at the time of transplantation, there is a risk of recurrence, so keep an eye on those patients. But often the transplant immunosuppression alone can put that patient in a remission, but as you taper immunosuppression over the years, you can get a late recurrence as well, so keep that in mind. And rituximab is a good drug because you're not going to throw a lot more at them unless you're very aggressive and want to use alkylating agents in that setting. So I think that's it with the references.